Welcome to Chagpar MD. I'm Dr. Anise Chagpar. As you know, this site is all about evidence-based health and wellness. And we are going to continue the conversation that we started having over the last week or so on prostate cancer. So we talked a little bit in the last couple of videos about screening and what you needed to know. But what about after you're diagnosed with prostate cancer? How do you know what your prognosis is going to be? What's the difference between grade and stage, Gleason score and Gleason pattern? What are some of the novel genomic factors that might actually influence your prognosis? Well, we're going to dig into all of those questions right now. So what do you say? Let's get started. So if you've just been diagnosed with prostate cancer or know someone who has, one of the most common questions is, what does this mean? What's my prognosis? The C word, whether for prostate cancer or any other cancer, is often one that really is filled with fear. But fear can be combated with knowledge. So let's dig into a few of the factors that actually influence prognosis and how that influences your treatment in turn. Now, if you didn't catch the last two videos on screening and what you need to know, I highly encourage you to go back and watch those because we'll be building on the information we covered in the last two videos. I'll leave you a link in the description box below. Now, as we had mentioned last time, prostate cancer is the most common cancer occurring in men, and it's the second leading cause of cancer-related deaths. This year alone, over 191,000 men will be diagnosed with this disease, and a little over 33,000 men will die from it. Now, the good news is that about 90% of all prostate cancers are found at a local or regional stage when the survival rates are really good. 5-year survival is close to 100%. But that is because most of them are found at a local or regional stage. When you consider prostate cancers that are diagnosed late at a distant stage, well, then the 5-year survival is more like 31%. When you take all comers, given the fact that most people find their prostate cancer early, 10-year survival for all stages combined is 98%. But what is it for you? And what are the factors that go into your prognosis? Well, there are a number of things that go into prostate cancer prognosis. One is, of course, stage. And stage for prostate cancer, very much like for other cancers, is really based on what we call TNM. TNM stands for tumor, nodes, metastases. So how big is the cancer itself? In the case of prostate cancer, is it confined to one lobe or both? Can you feel it on digital rectal exam and so on? N for lymph nodes, has it involved the regional lymph nodes around the prostate gland or in the pelvis? And M for distant metastases, has it spread outside? So for example, gone to bones or brain or other organs. The next factor is grade. And for prostate cancer, grade is really based on what's called a Gleason pattern or a Gleason score. And we're going to talk more about that. But essentially, grade is looking at the cancer cells themselves. How much do they look deranged? How far have these normal cells really turned into cells that look completely abnormal? And finally, there's PSA. Now, we talked about PSA in the segment on screening, but it's important here to realize that PSA, even after you're diagnosed with prostate cancer, has a role to play in how well or how poorly you do. Remember, PSA is a marker that is secreted by the prostate gland. And so the three of these combined really go into dictating your prognosis. Well, let's dig into each one of them in a bit more detail, starting with grade. So remember that in cancer, many cancers are heterogeneous. They are not all the same throughout the entire tumor. You may have some areas that look very bad and other areas not so bad. Well, In prostate cancer, we really take advantage of this tumor heterogeneity by sampling multiple areas of the prostate. We then grade each area and assign each area a score. This is called the Gleason pattern. Now, that pattern tells us how deranged these cells look. Cancer cells, remember, are just normal cells that have lost any kind of regulation. So as they get more and more deregulated, they become more and more abnormal, and so that score goes up. So if you look at this diagram, you can see where you have small uniform glands. This is a pattern 1. As there is more stroma between these glands, still looks pretty normal, but not quite like the grade 1, you start getting into a Gleason pattern of 2. It's only when you start getting into Gleason pattern 3 that you start seeing really distinctly infiltrative margins, cells that look really quite abnormal. When you get into 4, these start forming irregular masses of neoplastic glands. And in 5, there's really only occasional gland formation. These cells have gone completely wild. So what a pathologist will do in a prostate cancer is take 2 areas, the largest area and the second largest area, and give each of those areas a score on the basis of 1 to 5. And so you will get a grade that looks like this. For example, if the largest area was a 4 with irregular neoplastic glands, and the second largest area was a score of 3, you would get what's called a 4 plus 3 equals 7. So we would call that moderately differentiated. Now, although you would think that the scores really go from 2 to 10, adding 2 areas that go from 1 to 5, scores of less than 6 are really quite rare. And that makes sense if you look at this pattern, because 1 and 2 are really normal looking cells, what we call well differentiated. As you get into the more abnormal looking cells, you start getting more moderately differentiated, and when you're in 4 and 5, really poorly differentiated. So how do we put this all together? Because clearly a 6 sounds like it should be terrible, or at least mid-range, when actually a 6 is pretty good. And a 7 may not be the same as a 7. So a 4 plus 3 means that most of it looks really rather irregular, whereas a 3 plus 4 means that most of it looks just like it's starting to invade. So in order to get around these kind of quirks in this system, we come up with a grading score. We're going to get to that in a minute. But first, you need to understand that grade of a Gleason score of less than or equal to 6 is what we call low grade or well differentiated, 7, moderately differentiated or intermediate grade, 8 to 10, poorly differentiated or high grade. But again, a 7, a moderately differentiated or intermediate grade, might be a 4 plus 3, or it might be a 3 plus 4, which are a little bit different. So they've made Gleason groups, and there's 5 groups. So Gleason of 6 or less means that you've really got a well-differentiated tumor. 2 and 3 are intermediate, with 2 being a 3 plus 4 and a 3 being a 4 plus 3. 4s and 5s are really the higher grade tumors. Gleason 8 for a Gleason group of 4, and 9 or 10 for a Gleason group of 5. So prognosis gets worse as the Gleason group number goes up. Now, what about PSA? When we talked about screening, we talked all about the controversies that go into PSA tests. In screening, a PSA test of less than 4 is normal, but it's not a guarantee that you don't have prostate cancer. 4 to 10 is borderline, with a risk of about 25% of having prostate cancer, and a prostate-specific antigen test of more than 10 is a high number for screening, but still, it only means that you've got about a 50-50 chance of having prostate cancer. We still use PSA, however, once you're diagnosed with prostate cancer to help in staging. And I'm going to show you that here. So when we think about prostate cancer staging, we use a combination of TNM, the grading group score, and the PSA. So stage 1 is really small tumors, T1 or T2, that either can't be felt or limited to one lobe of the prostate, no lymph nodes involved, no metastases, well differentiated, grade group 1 with a PSA of less than 10. Once you start getting larger tumors that might be in both lobes of the prostate, or if your PSA is between 10 and 20, now you're into the stage 2A. Well, once you start getting even higher in terms of the grade group, you're into a 2B. And when you're into 3s and 4s for the grade group, so remember now you're into that intermediate grade group and going into the more poorly differentiated tumors, you're now into a 2C. Once that PSA starts creeping up over 20, however, now you're into a stage 3A. And as the tumor increases in size and spreads beyond the prostate to regional structures, you start getting into the stage group of 3B. If you have poorly differentiated cancers, that Gleason grade group of 5, you're a stage 3C. And once you're in the lymph nodes, that's 4A, or if it's spread to a distant site, it's an M1. So when we talk about localized or local regional disease, we're really talking about stage 1 to 3C. 4A is what we call regional or nodal metastases, and 4B is distant spread. Now, the NCCN has put this together in terms of risk groups that helps guide your treatment and how you think about things. And it puts together your TNM, your grade group, and the PSA, as well as a few more factors. I am leaving you a link in the description box below for the NCCN risk groups, as well as a really great guide that was put out by ASCO, which is the American Society of Clinical Oncology, that can help you go through all of this information, including your risk stratification and prognosis. So the NCCN divides risk groups into 5 main groups. The very low risk are people who have a T1C stage and they're group 1 in terms of their grade, and their PSA is less than 10, and they only had cancer in 1 or 2 cores, but no more than half showing cancer, and their PSA density is less than 0.15 nanograms per milliliter per gram of prostate. So remember, PSA is an antigen that's produced by the prostate. The larger the prostate, one could imagine the more PSA it produces. So the PSA density controls for that by dividing by the weight of the prostate, or the estimated weight. In terms of treatment for these patients who are in the very low risk group, if the life expectancy of the patient is less than 10 years, really observation is all that you need. For 10 to 20 years, it's active surveillance. And even for those who have a life expectancy of more than 20 years, active surveillance is still the preferred method. So what is active surveillance? Well, it's not just observation. It actually is observation with continued monitoring, which may mean biopsies roughly every year or so to really keep an eye on that cancer and to see if it's changing. Remember, the vast majority of prostate cancers are indolent, and if it doesn't change and it's a very low risk, you may not need any active treatment whatsoever. However, if your life expectancy is more than 20 years and you're uncomfortable with active surveillance, there are other modalities that you could use as well, including external beam radiation or brachytherapy and or surgery with radical prostatectomy. Now remember, the reason why active surveillance is preferred is because the other more active modalities of treatment actually carry side effects in terms of the complications of the treatment itself, which may outweigh the benefit that they carry given the very low risk of the cancer itself. What if you're in the next group up? So the low risk group, again, if you have a fairly small tumor, T1 to 2A, and you're in grade group 1 and your PSA is less than 10, if your life expectancy is less than 10 years, again, all you need is observation. More than 10 years, active surveillance is preferred, although you certainly could consider radiation or surgery. Now, the intermediate risk group is actually tumors that are T2B or T2C, or they are grade group 2 or 3, or PSA 10 to 20. So really in that mid-range of all kinds of factors. And in fact, the NCCN breaks this out too into the favorable and the unfavorable. But in general, if life expectancy is less than 10 years, observation is preferred, although you could consider radiation therapy. If your life expectancy is more than 10 years, active surveillance is considered, especially in the favorable group, but you could also consider external beam radiation or brachytherapy or surgery, especially for the unfavorable intermediate risk group. Now, once you start getting into a T3A or grade group 4 or 5, so really more towards that poorly differentiated group, or your PSA starts creeping up over 20, now you're in the high risk group. If you have tumors that are T3B or T4, or the tumors are primarily Gleason 5, that's what NCCN calls a very high risk group. For both of these, if your life expectancy is less than 5 years and you're not having any symptoms, recommendations are really for observation, although you could consider androgen deprivation therapy or external beam radiation therapy. If, however, your life expectancy is more than 5 years or you're having symptoms, you could consider radiation or radical prostatectomy. Now, what if the cancer has already spread to the lymph nodes? Well, this is what NCCN calls a regional risk group. And again, treatment is dictated by life expectancy. So if your life expectancy is less than 5 years or you're having no symptoms, this can be treated with observation alone or androgen deprivation therapy. If your life expectancy is more than 5 years or you're having symptoms, then you could combine external beam radiation therapy with androgen deprivation therapy, which is the preferred modality, or consider androgen deprivation therapy alone, or consider androgen deprivation therapy with a variety of other medications, including steroids. All right, so how do you know? How do you know if your cancer has spread beyond the prostate? How do you know if lymph nodes are involved? How do you know if it's gone to other organs? Well, imaging plays a key role here with CT, MRI, and PET. And these really help to define where the cancers have gone and give your urologist or your cancer team a good sense of the extent of disease. These days, more and more, MRI is also being used to really carefully map where the cancer is, and frequently now can be juxtaposed into ultrasound to help guide further biopsies or even treatment. I do a radio show called Yale Cancer Center Answers, where I interview a number of specialists here at Yale, often on a variety of topics. We recently talked to some of our urologists about these, and I'll leave you a link to the podcast in the description box below as well. Now, one of the most frequent questions I get asked all the time about prostate cancer as well as other cancers is, well, what about all of the latest novel genomic tests? We've come a long way in terms of unlocking the genome and figuring out what really makes cancers tick. So can these cancers tell us more about my prognosis? And the answer is yes. There are a variety of novel genomic tests out there on the market for prostate cancer, but it's important that you realize that each of these tests tells us a little something different about your cancer. So Oncotype Dx prostate, for example, really gives you the risk of having adverse pathology at the time of radical mastectomy. I mean prostatectomy. You can tell that I'm a breast cancer surgeon. Prolaris tells you about the risk of prostate cancer death in 10 years with conservative management. And Decipher really tells you about your risk of metastases. I've left you a link to a review article in the description box below where you can find out more about these tests. Now, as always, this series of videos and this YouTube channel in general is designed to be evidence-based and for your education so that you can have really meaningful conversations with your doctor. This is not to be considered medical advice, but it is helpful that you have some understanding of the questions to ask your doctor and to really help you to decipher some of the language that they may be using that sometimes can just go over your head. So I hope that that video has been helpful for you. I hope that you gained more insight into what goes into grade and stage for prostate cancer and how that really affects your prognosis. I hope that you will like and share this video. Leave me your comments in the description box below. Have you had prostate cancer? What was that like? How was your treatment different? And so on. And please do subscribe. Remember, we are trying to build a community of people who really want to get evidence-based information about health and wellness. And I am so happy that you are part of this community. Until next time, I'm Dr. Anise Chagpar wishing you all a safe and healthy week.